Okay. All right. So we'll start with the PowerPoint. If you guys have any questions, you can unmute while we go. Okay. So this is the PowerPoint that's under week 10 information. There's also 2 PowerPoints that are under week 9. So make sure you're peeking at those as well. Okay. Okay. So in preparing for a test, obviously the more you hear the information, the more likely it's going to commit to long-term memory and stay there. So go back, listen to if there's lectures that you felt like, man, I really struggled with that information. Listen to those lectures. Listen back to the exam reviews. Professor Stiles has done a weekly HESI review from your HESI book. So that those are really helpful to a lot of students. So be listening to those. If you're not sure about why something's wrong or right, you can always reach out to me, or you guys can start study groups to kind of help you study for the HESI. Cramming is not something you should do because it just stores in short-term material. So it's not something that you guys are going to remember to utilize further, as you go on to your NCLEX, taking your NCLEX, okay? Do not reread the textbook. You should have already read it, okay? If there's something you're confused on and you feel like you need to go back to your textbook to clarify, then that would be okay to reread. But most of what you should do is look at the HESI review book, and I would say do the HESI weekly reviews that Professor Stiles posted. Don't stay up really late the night before your test. Obviously, eat and be well hydrated. And you can do things like deep breathing or other relaxation type techniques before as you're doing your test if you're feeling like you're getting kind of worked up about something. While taking your test, try to stay positive, okay? If you think like you get a question and you're like, oh crap, I didn't study that again, or I didn't look back at that, or I can't remember that, try not to let that then affect your test going forward, okay? Be there 15 to 30 minutes early, so that way if you have computer issues or what have you, you have plenty of time, okay? Like I said, if there's a question that you didn't study the material, or it seems like a really difficult question, I mean, I wouldn't spend a lot of time on that question. I would try to get as many of the questions, correct as you can instead of wasting a lot of time on something that you're not sure about. Okay. If it's a math question, recalculate it. Okay. So like you get your first answer, go back through it again and make sure that you get the same answer again. Because if you're getting multiple different answers, then, that can show you that potentially you're calculating something incorrectly. Okay. Don't skip over anything. Reread the questions. If there's an answer that's really jumping out at you, a lot of times that's kind of a trick answer. Okay. Not always, but a lot of times it is. So read back through before you pick. You guys have plenty of time on your HESI. Okay. Multiple choice, like I said, read over all the options before you make a decision. Eliminate any options that you definitely know are incorrect. And then eliminate options also that aren't related to the subject of the question. Okay. For your next gen questions, once again, read all of the data, okay, before you go to picking answers. Don't just skim over and skip over or look at one thing really quick. Read through the whole thing before you start making decisions. Okay. And then use your clinical judgment to answer those questions. Okay. Fill in the blank. So like dosage or I and O. Make sure you're following the directions within the question. So if it tells you what to round, it tells you, what unit of measure it's looking for at the end for the answer. Make sure you're putting it in that from your calculation, okay? You can use scratch paper, but in the NCLEX, you'll have like a whiteboard that when you're sitting in NCLEX that they give you, okay? Set up your calculation like you should, okay? And then obviously do all your conversions and then perform your calculation, okay? And then make sure you look at for rounding, okay? What it's looking for. And do not round until the very end of the problem, okay? Because if you round early on, like you round with your kilograms or something, it's gonna adjust your answer at the end, just enough that might throw you off. Okay, so for your multiple response, so like select all that apply, obviously airway, like priorities, right? So airway, breathing, circulation, that would be high priority. Looking at Maslow hierarchies of needs as well. This is like going to help you kind of pick potentially your select all that apply that are the highest priority. Looking at the steps of nursing process. So look back at that from week 1. Strategic words. So words that kind of gear and kind of point you to what exactly the question is looking at. Okay. Mental imaging, that can be helpful. You always wash your hands before you touch the client, like the kind of those basic things. Okay. For scenario, or like you have a case study, like I said, read through all of the data. Okay, click on each tab of the medical record or the exhibit that they're showing you, so you're not missing anything. Okay. And always reread before you pick an idea or an answer. So test taking strategies. So if you have no idea what the answer is, there are some questions that you can try to make an educated guess. Okay. So avoid picking always, never, must, cure. Okay. So if you're going to make an educated guess and your answer has one of those words in it, I probably would try to avoid that question or that answer for that question. Okay. Don't overread into the question. I think a lot, just looking at this last exam, I think some of you guys struggled with that one. Like we read into the question a little bit too much with the select all that apply. Okay. Least invasive first. So usually that's what you would pick, is the least invasive thing to do first. Obviously, if they're not breathing or something like that, and you're having to do something more invasive, then pick that. But usually, to make a good educated guess, picking the least invasive is a good option. You're going to assess before you do any interventions or treatments, okay? Unless they're in distress. Okay. You're going to assess your client before you look at the machines and the equipment. But know that also looking at the machines and the equipment is important as well, especially if your patient isn't looking distressed, but your equipment is showing that they're looking distressed. Okay. Any answer that delays care to your patient is usually a wrong answer, so avoid those ones too. Okay. If 2 answer choices are opposites, then one of those options are usually the answer. If 2 are similar, then usually you can get rid of both of those answers. Okay. Obviously, if one part of the answer is wrong, it's all wrong, so don't pick that answer. And then therapeutic communication kind of skills, so like open-ended questions. If there's an option where you're using an open-ended question, then that's usually a good option for an educated guess if you're not sure of the answer. Okay, looking back at developmental milestones. So birth weight should double by 6 months and triple by a year. Length increases by 50% in 12 months. Posterior fontanelles close at 8 weeks. Babies start with social smiles, typically, or they should, at 2 months. They're turning head to locate sounds at about 3 months. Your moral reflex goes away about 4 months. So that's that startle response, okay? Steady head control at 4 months, completely turning over both ways. So back to belly, belly to back by 5 to 6 months. And then playing peekaboo after 6 months. Peekaboo might be something that comes like 7, 8 months, okay? Transferring objects from one hand to the other, that's about 7 months. Stranger anxiety comes about 7 to 9 months, and then you'll see it come again about 15 to 18 months. And those are just normal developmental things. It's important to explain that to parents. So that way they can explain that to like grandparents and things who used to hold baby without any issues, and now all of a sudden they're having problems. Sitting unsupported by about 8 months, crawling at 10 months. That fine pincer grasp, so that's going to be pointer finger and thumb grabbing and picking up and putting to the mouth. That's between 10 and 12 months. Waving bye-bye is about 10 months. Walking with assistance is between 10 and 12 months. Simple words, mama, dada, at 12 months. And then exploring their environment by motor and oral means. Okay. So a HESI hint, make sure you know the stages of separation anxiety: protest, despair, denial, detachment. You guys can't quite remember those, go back and study those again, okay? Okay, birth length doubles by 4 years of age, okay? Child sitting unsupported, 8 months. Kids are gonna be half of their adult height at 2 years of age, which is crazy to think about, but that's how much growth happens in the first 2 years. Throwing a ball overhand, that's by 18 months. 2 to 3 word sentences is by 2 years. Using scissors at 4 years, supervised. Okay. Child tying their shoes by 5 years. Okay, so if you have a question of, okay, is this intervention that we're doing helpful to this infant? So, for example, this question, is the thyroid hormone therapy for 4-month-old effective? How would you assess that? Well, if they're meeting their milestones, they're growing, they're adapting to their environment, then I would say that that intervention is effective. If they're delayed in their growth and development, then you might want to be looking at that intervention again. Girls go through growth spurts through puberty prior to boys. Girls typically can go through puberty as early as 10 years of age. Boys, it's closer to 12 or 13. Okay. Temper tantrums, common in toddlerhood. If it's going further than toddlerhood, then that's not developmentally appropriate. Okay. And then obviously adolescence is a time where they're trying to figure out their identity. They're trying to see where they fit in. So it's not uncommon to see a lot of rebellion in family values for that age group. Okay. School age kids, remember Erickson stages. Okay. They're industrious, meaning they like to do and accomplish things in school age. They also like to interact with their peers and their peers' ideas, and those peer friendships are kind of becoming more important than family relationships at home. Okay. But parents are still, the number one person for school age kids.
I'm sorry. What's the ages for the school age starting and ending again?
So 6 to 12.
Okay, thank you.
Yep. So those kids that are in like elementary school. So kindergarten to, 5th or 6th grade, depending on what elementary school you go to. Okay. Okay. So infants, obviously more risk for bodily injury after 6 months because they're more active, right? They're not just laying in one spot, they're rolling, so they can gain access to things like electrical cords or electrical outlets, stairs, things like that. Okay. Toddlers, remember, they're fearful of those intrusive procedures, so getting poked. They think that you're going to take all their blood. Preschoolers, they fear body mutilation. So if you talk about them having to have surgery, they think that you're going to, they have to have surgery to fix their broken arm. They think that you're going to cut off their arm. Okay. School age kids, they fear loss of control of their body. And then adolescents, it's body image concerns. Okay. Accidents are the biggest cause of death in children and adolescents. Okay. So you guys should be aware of teaching, like safety teaching, things that you can do with the RN in teaching parents and children about how to prevent those accidents. So how could you teach a parent about how to prevent burns on a 3-year-old?
Turning the handles away.
Yep. Yep. What about like what could you teach parents about reducing the risk of potential accidental ingestion?
Keep like chemicals away from children and lock them away.
Yeah, and
For the buy-in.
medications too, right? Because guess what? Liquid Tylenol, some kids really like the taste of it. So they might try and climb up and serve themselves some liquid Tylenol or some chewable Tylenol. Okay. What about adolescents? What could you teach adolescents? What would be a safety thing for them?
Wear their seatbelt. Make sure they have like no crossing the road and stuff like that.
Yeah. Staying off their phones while they're driving. Good. What else?
Drugs
Yeah. Drugs.
and sexual transmitted disease.
Yep. Good. Yeah, so just be thinking about all of those things because your HESI, they're going to ask a lot of questions about like teaching and interventions as far as like critical thinking skills and making teaching plans and doing your nursing process. Okay. Okay, pain scales. So remember way back to weeks 1 and 2 where we talked about the different pain scales. So cries, that's for infants that are preterm. Okay. So that scores from 32 to 60 weeks of gestation. Your PRS, that can be used up to 3 years of age, from 1 to 3 years, or 1 month to 36 months. Faces, so that is looking at the scale that has the happy face for 0 pain and then a really sad face that's crying for 10. That can be utilized in kids who are preschool age, so 3 to 5. Okay. The numeric pain scale should not be used for any kiddos under the age of 9. Okay. Now, that's per the book. You might have a really smart 7 or 8-year-old that would understand the numeric scale and be able to give you an appropriate answer. But as far as for the HESI, 9 and up. Okay. The Oucher scale, so that's between ages 3 to 12. That looks at providing culturally specific photographs and showing those different cultures at different levels of discomfort. Okay. Documentation of pain is obviously the child's self-report. So if they point to the happy face and they're crying, you may want to kind of re-ask that question. Maybe they're not understanding that scale that you're trying to use. Maybe they're a little bit developmentally delayed, and you have to utilize another scale. But if they continue to say that they're at a 1 and they look like they're at a 8 or 9, then that is the pain is what that child says it is. Okay. Nonverbal children or like infants, you can utilize the FLACT pain scale, which looks at facial expression, leg movement, activity, cry, and if they're consoluble. Okay.
I have a question.
Uh-huh.
I was looking at the book today,
Mm-hmm.
and there is a table 5.2 and with pediatric pain management. And here they state that toddlers numeric rating scale 1 to 10 or visual analog scales faces. Then
Uh-huh.
school age to adolescents numeric rating scale 1 to 10 or visual analog. So is this an error in the book?
No, you can utilize the FACES scale in older.
No, numeric. I am about toddlers numeric rating scales, they state in the book.
I wonder if they're talking about the poker chip scale.
No, it's just
It just says numeric.
Yeah.
Huh.
So, but it's not.
I would not utilize
Yeah.
numeric in a toddler.
It just confused me. I'm like, what's going on?
Yeah. Yeah. No, I would utilize the FACES or the poker chip scale. Okay. Okay. And then obviously you're going to, if they're not having significant severe pain, you're going to try and implement non-pharmacologic interventions first. Okay. And you're utilizing non-pharmacologic interventions that are based on that child's age and development. So pacifiers with that little sugar water. Remember we talked about sweeties being almost as effective in studies for NICU babies as morphine and reducing their pain. So pacifiers with little sugar water, holding, rocking the infants, singing to them, things like that for non-pharmacologic interventions. Toddlers and preschoolers, distraction is probably going to be your best technique. So reading, TV, music, blowing bubbles, playing with others. Okay. And then you want to implement pharmacologic interventions before their pain is like way out of control. Okay. So ideally, especially if you have a kiddo who had surgery or something like that, you want to be doing around the clock pain medication, at least for a period of time, shortly after they've had their surgery. Okay. Obviously, if you're going to be doing opiates or something that can suppress their respiratory drive, you're going to be doing your vitals prior to giving those medications. PCA pumps, 5 years old and up. Okay, we're not using PCA pumps on kids less than 5, just because they have to be the ones to hit the button and determine that they're having the pain, not parents. Okay. Remember, kids will say that they're not having pain on because they're fearful for having to have an injection or a needle to get that pain medication. Okay. Or they don't like the taste of the liquid. Okay. And then always before you give any medication, but especially pain medication, you guys should be doing your weight-based drug calculations to make sure that that's accurate and appropriate for that kiddo. Okay. Okay. Common childhood diseases. Well, we are seeing more of these happen now. Measles. So measles, a lot of times you won't necessarily notice the complex spots, but these are teeny tiny little white dots on the inside of the mouth. That usually kind of is the first thing that starts, and then you start to see fever, headaches, congestion, coryza, so like, upper respiratory kind of symptoms, conjunctivitis, so the eye redness, and then the rash begins. Usually starts at the face and spreads down to the rest of the body. Okay. Anyone know if their state has an outbreak right now of measles?
No.
No, I haven't seen. What we have Florida, right? I haven't seen any in Florida yet. But I think New York, Texas, Kentucky, Pennsylvania. There's a couple others. And obviously we have a vaccine for the measles. So it's the MMR vaccine. They get two doses, one between ages 12 and 15 months and one between ages 4 and 6 years. If they have those 2 doses, they are essentially 97% covered. Okay, from not getting measles. If they only have one of those doses, they're about 90% covered. Okay. But there's been a drop in the amount of vaccines that people are getting. So that's why we're seeing these outbreaks come about. Okay. Varicella zosters or chickenpox vaccine. So chickenpox has an incubation period of about 13 to 17 days. So after exposure, about 2 weeks after exposure is when you'll start to see this. These lesions appear. They usually start on the trunk and then spread to the face and the extremities. The rash starts on the trunk as a flat or macular rash, and then it becomes papular, so kind of raised, and then you see that vesicle, so that blister form. But you will see the lesions being in different form, or the rash being in different forms all throughout the body. So on the trunk it might look vesicular, but on the arms it's going to look macular, so it's going to be flat. So they'll be kind of in different stages, all the lesions. They are infectious until the scabs are on all of the lesions. Okay. So they can continue spreading chickenpox until all of the lesions are scabbed up. Varicella vaccine, same range, between 12 and 15 months and 4 to 6 years of age. Okay.
Is this the one that has, I'm sorry, is this the one that has a prodromal phase? And is that when
Yes.
they're not,
Yep.
That's when they're not contagious?
Yep.
And that's about how long after initial contact?
Well, it takes about 13 days. So the prodromal phase is usually a few days, so like 3 to 4 days before they start then with the rash. But as far as incubation period, so from the time they've contacted somebody who had chickenpox, it's going to be about 2 weeks before you know if they're going to have chickenpox or not themselves.
Okay.
Okay. German measles, rubella. They, just like with regular measles, the rubella is a significant threat if moms are pregnant, and those babies have, and their other kiddos have German measles or rubella. Okay. It's more likely to cause miscarriage and birth defects in the expecting mamas. Okay. So any kiddos with communicable diseases, obviously you want to have those children isolated while they are infectious. Okay. We're not treating with aspirin. Okay. So we're treating fevers with Tylenol or acetaminophen or ibuprofen. And we don't use aspirin because of Reye syndrome risk. Do you guys remember what we do use aspirin for? Think to your hematology unit. No?
Are you using it for an anticoagulant?
Yep. There's one specific
Is
disease.
Is it Kawasaki disease?
Kawasaki's, yep. That's one. And then the other, sometimes
What's the other one?
MISC,
Yes, that's the other one.
multi-system
Yes.
inflammatory disorder, okay? Which is very, very similar to Kawasaki's, but good job for remembering Kawasaki's. And those kids are on aspirin because of the risk of clots in their aorta, okay? But otherwise, no aspirin, okay? Obviously with chickenpox, it's gonna be really itchy. That rash is super itchy. So keeping their nails short so that way they're not picking and scratching. Having them wear mittens, so if they are scratching, you know, they're just kind of rubbing. And then soaking in some soothing baths, so like oatmeal baths or things like that. Okay. Can also use Benadryl or diphenhydramine. Okay. And then making sure you're telling the parents to wash their hands, and public health will be in contact with them. Okay. Measles is an airborne disease too. It's not by contact. Chickenpox is also considered airborne, but kids are more likely to get it if there's, you know, contact with the actual lesions. Okay. Most common nutritional deficiency is iron deficiency, typically between 12 and 36 months. And then adolescent females, and then females who are in their childbearing years. So females who are pregnant. Okay. Why is it more common that kids are iron deficient between 12 and 36 months?
Because they're starting to wean off the breast milk and formula.
Uh-huh. And what are they doing instead?
Going to whole milk
Uh-huh.
and maybe not taking vitamin C with it.
Yeah. Or eating like green leafy veggies, right?
Or yeah, right.
Or like really red meats that are higher in iron.
Mm-hmm.
And then with the milk, is there something about milk that affects your iron absorption?
Yeah, I thought it was you're supposed to take with vitamin. Oh wait, is it vitamin D?
No, it's vitamin C. You were right. That
Okay, I
helps
was right.
absorb.
See,
Yep, that helps absorb. But the cow's milk, it binds, it competes with iron in the gut on the hemoglobin. Okay.
oh yeah,
But then the
yeah.
iron can't bind as well to the hemoglobin, so they're not as effective. So that can actually worsen iron deficiency. if they're doing a lot of cow's milk. Okay. Vitamin A, vitamin C, B6, B12, those are all tend to be more common deficiencies just because kids don't eat enough of those foods that can contain those vitamins. And then obviously in infancy and in adolescence, there is going to be more of a demand for increased calories, protein, zinc, calcium, iron, because of the accelerated growth during those time periods. Okay, so in infancy and in adolescence. Okay, so if you are trying to figure out, say you have an adolescent who you're concerned maybe has an eating disorder, one way you can do that is do a 24-hour recall and ask that adolescent to recall what food they've ate in the last 24 hours or keep track of a food journal. Okay. And then as far as the food groups, making sure that they're getting each of the appropriate food groups, an appropriate amount of each of those food groups daily. Okay. Okay, diarrhea. So there's different reasons why kids get diarrhea, sometimes infectious, sometimes based off their diet. Okay, but across the board, the complications of diarrhea are the same. Obviously, if they're losing fluid, they're going to become more dehydrated because it's diarrhea and that's alkaline, right? We're getting rid of more of the alkaline, so we're holding on to the acid. So we're going to be in metabolic acidosis. Eventually, if they continue with diarrhea and they're not having like fluids, then they'll progress to shock and then eventually death. Okay. Signs of shock, obviously decreased blood pressure. You're going to have a rapid, weak pulse, mottled skin color, and then mental status changes. And not necessarily in that order. Okay. Okay. Signs of dehydration in kids, poor skin turgor. Okay, that's probably one of the last ones we check just because, just like with adults patients, you have to kind of pinch their skin to check that. So, but absence of tears, dry mucous membranes, a weight loss of 5 to 15 percentile. If it's an infant, their fontanelles will be sunken in or depressed, decreased urinary output, and then increase specific gravity on a UA if you do that. Okay. Pediatrics will almost always have potassium added to their IV fluids, their maintenance fluids, but you want to wait until that child has at least 1 to 2 mils per kg per hour for urinary output. Okay. Nursing interventions for diarrhea, obviously observing your hydration status and monitoring your vital signs, looking at I&O. If your kids are having diarrhea, do not take rectal temperatures because it's going to worsen the diarrhea because it stimulates that area. Okay. Rehydrate with fluid and electrolytes. So try to get parents to push oral fluids as much as they can to supplement. But if they're in the hospital, they're going to be on IV fluids as well. You may collect specimens, so they might be collecting the diarrhea to see what the cause of the diarrhea is. They'll check stools for blood, glucose, pH, checking the urine for specific gravity to check their hydration status. And then obviously, if kids are in the hospital and they have diarrhea, they're going to be in contact precautions. Okay. And because they're having diarrhea, you're going to be wanting to wash hands instead of just using hand sanitizer. Okay. Because C. diff, you know, it's not taken care of by hand sanitizer. You have to wash your hands. Okay, indicators of child abuse. Probably the biggest one is delay in seeking medical care. So if it was 4 days ago that this happened and parents are just showing up, that's kind of a concerning sign. Okay. Unusual bruising, signs of burns. Okay. Like, you know, a cigarette burn or an iron burn or symmetric pattern in their burns. Bald patches where their hair was pulled out, fractures in various stages of healing, failure to thrive. Okay. Or, you know, they have these physical problems that their parents haven't brought them in for, strained ligaments. Okay. And in every single state, you as nurses are required to report suspected child abuse. If it's unfounded, you guys are not liable as long as you're making that report in good faith. Okay. Another indicator is if the stories aren't lining up. So the child saying this happened, the parent saying this happened, and then, you know, the daycare provider saying this happened. Okay. Well, obviously, that's kind of a red flag. Poisoning. So obviously inhaling, ingesting, or absorbing a toxic substance. So syrup or Epicac is no longer recommended. So they will not give you the Epicac to make those kids vomit like they used to. Okay. So teach parents to not induce vomiting. Okay. Because what was happening is kids were kind of out of it. They were given Epicac and then they were aspirating on their vomit. And it was causing worse complications. Okay, respiratory disorders. So common signs of respiratory distress: restlessness, increased respiratory rate, increased pulse rate. You're going to see the increase in respirations and increased pulse rate before you see the retractions, the nasal flaring, the grunting. Okay. You're also going to see all of those things happen before you see the cyanosis or a decrease in their pulse ox. Okay. So one of the last things that will happen is the decrease in the pulse ox. So it's really important to keep an eye on these kiddos before they start, you know, before it's their pulse ox that's dropping. Okay. Head bobbing, all of that. Okay. If you get a blood gas on a kiddo in respiratory distress, they're going to have a decreased PO2 and elevated carbon dioxide. Okay. Because they're starting to get respiratory acidosis. Okay. Cyanosis and paler, very, very late signs. Okay. All right. Nursing plans and intervention for asthma specifically. Rescue inhalers or rapid acting bronchodilators, and steroids will be given in acute attacks. So in an exacerbation. A lot of times kids are on beta adrenergic agonists like albuterol, or also like combinations of the long-acting beta agonists with corticosteroids like Symbicort or something like that. And those will be the ones that are utilized daily, okay, for maintenance. The rescue inhalers are when they're having a flare-up. Not uncommon also for kids to be on oral steroids while they're having an asthma exacerbation. Maintaining their hydration, maintaining compliance with their routine medications. Okay, this will help reduce their risk of exacerbation. giving them oxygen or neb treatments as needed, and then monitoring their pulse ox. Okay. Okay. Cystic fibrosis, remember this is a multi-system disease. Okay. So it's listed under respiratory, but it affects multiple systems. Okay. Lung insufficiency is the worst defect that happens with cystic fibrosis. Pancreatic insufficiency, though, as well. Loss of sodium and chloride in the blood, or excuse me, in the sweat. So they're going to have very salty tasting sweat. Biliary obstruction, so the liver is involved, and then dysfunction in the reproductive system because of all of that mucus buildup. Remember, boys with cystic fibrosis are infertile or sterile until a year after a double lung transplant, at least. Okay. Women are not considered sterile or but they may have some problems getting pregnant. Okay. A child who's diagnosed with cystic fibrosis requires 1.5 times, so 150% of the usual caloric intake of a healthy child to grow normally. And do you remember what they have to take with their food?
Pancreatic enzymes.
Yes. Good. Good. So obviously with lung insufficiency being the biggest factor for these kids with cystic fibrosis, getting a respiratory infection is probably the most problematic thing that can happen for these kids. Okay. So trying to prevent that, or if there's signs of an infection, they need to be on antibiotics or what have you as soon as they can. Okay. They also have a hard time absorbing fat soluble vitamins. Okay. So those have to be given in water soluble form, and those fat soluble are A, D, E, and K. Okay. Administering oxygen or neb treatments. They're going to have that chest physiotherapy, so the vest or the little cups for the younger kiddos. They'll have to be doing those multiple times a day, especially if they're having a respiratory infection. They're always going to get their pancreolase or the pancreatic enzymes. Okay. Dietary recommendations: high calorie, high protein, high fat. Okay. You don't have to totally limit carbs, but you don't want to give them a bunch of carbs because of the risk for increasing CO2 drive. Okay. And if they're in the hospital, providing age appropriate activities for these kids to do. Administering oxygen. Oxygen hoods are used for infants. However, like I told you guys when we talked about this, I have not seen an oxygen hood used in years. The nasal cannula, so the prongs, are probably the most common. Nasal tents, or the oxygen tents, those also haven't been utilized for very often, but if you do have a kiddo that's in an oxygen tent, you want to monitor their temperature. Okay. Pulse ox, that looks at the oxygen in the arterial at the hemoglobin. So if kids are anemic, that can affect their pulse ox reading. So keep that in mind. If you have a kid that's chronically low, it may be because of their anemia. Okay. So set your alarm parameters. So usually it's going to be if they drop down to 95% or less. Okay. Blood gases, those will probably be done routinely. A normal peripheral oxygen is 83 to 100. Normal CO2 is 35 to 45 for infants and children's. Newborns are going to be a little bit higher. Okay. Okay, epiglottitis, this is straight to the ER. They're gonna need intubated potentially or trached. Okay. Most commonly caused from Haemophilus influenza B type B or Hib. We give that Hib vaccine at 2 months, 4 months, and 6 months. Okay. Do not look in these kiddos' throats if they're drooling a ton and you're concerned that they have epiglottitis. You let the provider look. Okay. You don't worry about looking. Okay. Because that can cause them to have a bronchospasm, and then that epiglottis will just swell right over their larynx. Okay. And you're going to want to have your intubation kit and all of that right at the bedside, and a trach as well. Okay. Bronchiolitis. Okay, so this is inflammation in the bronchioles, which are the small airways of the lungs. Okay. Most commonly caused by respiratory syncytial virus or RSV. Okay. If kids have RSV or whatever is causing their bronchiolitis, they're going to be in a form of isolation. So they're going to be by themselves. They may be just have droplets. So it may just be that you need to wear a mask and a face shield. It may be that they have RSV, which is contact and droplets. So you're going to be gown, gloves, mask, face shield. Okay. Or they may have something like tuberculosis where you have to be in, the full airborne precautions. Okay. Obviously in kids with any respiratory disorder, but especially bronchiolitis, you want to do have meticulous hand washing. You're going to be monitoring their respiratory status, clearing their secretions with bulb syringe or with the wall suction and saline. Okay. Sometimes an antiviral agent will be given, but almost never, unless they're very, very sick. Okay. Synagis or palsimimab, that's a passive immunity. So it's antibodies, monoclonal antibodies against RSV that are given to kids who are high risk at less than 2 years of age. So these kids may have congenital heart defect, they may have a lung disease or history of significant prematurity, so like less than 35 weeks. They'll qualify to get the Synagis. Synagis is once a month during the entire RSV season, so usually from November to March. Okay. And like I said, it's a vaccine form, so they have to get a shot, but it's monoclonal antibodies. Okay. So it's antibodies against RSV. They do now have Fortis is what it's called. And that is the newer RSV monoclonal antibodies that just kind of came out within the last couple of years. That is 1 dose for the season, and it covers them for the whole season. Okay. Obviously, with any respiratory process, maintaining their airway is your priority action. Okay. Respiratory disorders are going to be the most common reason why kids come to the ER or come to the hospital. Okay, so these are often asked about on the NCLEX and also on the HESI. So know your normal respiratory rates, know your normal cardiac rates, okay? And know the signs of respiratory distress. Okay, any questions about respiratory before we move on to ENT?
I had a question about like the most common drugs we'll see for the respiratory, because I see it has one there. If there's like some we should be knowing.
Well, for asthma, obviously all your inhalers and nebulizers, right? Know the difference between You know, corticosteroids, those are going to be more maintenance. Those aren't going to be the rescue drugs. Your short acting beta agonists are going to be your rescue drugs, so albuterol. But as far as with RSV and all the other viral things, there's not a lot of drugs that they give kids for that. So it's going to be oxygen support and maintaining their airway and making sure that they're staying hydrated.
Okay, thank you.
But with cystic fibrosis, you know, they're going to be on inhalers, neb treatments, the pancrealase, so the pancreatic enzymes, the fat soluble vitamins in water soluble form. Okay. Okay, moving on. Otitis media. So this is an inflammatory disorder of the middle ear, so back behind the TM. Okay. It can be suppurative, which is like pus filled, fluid filled, or it can be clear fluid or serous. Okay. For otitis media, these kids will get antibiotics. Okay. There can be viral otitis media, but you can't determine whether it's viral or bacterial just by looking at an ear that's infected. So antibiotics are still utilized. Sometimes these kids have really high fevers. So if they are having a fever, obviously you want to maintain kind of normal body temperature. But if they are having really high fever, you give them medication to reduce that fever and it drops really quickly, then they're more at risk for having seizures. Okay. So febrile seizures. Tepid baths, so kind of lukewarm baths. Do not use cold water, ice, rubbing alcohol, any of that, because that drops their body temperature too quick. Tylenol or ibuprofen. Remember, we cannot use ibuprofen in kids until they're 6 months of age. Okay. Have that child lay. Usually it's most comfortable to lay on the side that's bothering them. Okay. And then you can put a warm compress to that ear. And then make sure you're telling parents to complete their antibiotic as prescribed. Okay. So otitis media is the middle ear. Otitis externa is swimmer's ear. Okay, so that's the external canal that's irritated and swollen. Okay, for that, they'll get ear drops. If it's a middle ear infection, they'll get oral antibiotics. Unless they have ear tubes, then they'll get ear drops. Okay. All right, tonsillitis. So it can be bacterial, it can be viral. Probably the most common form of tonsillitis you see is strep tonsillitis. So group A strep. Remember, if kids are getting their antibiotic for their group A strep and they're not finishing it, it is not uncommon to see glomerular nephritis. So that overactiveness, that over response of the glomerular tissue and the kidney becoming irritated and enlarged, so they're holding on to their fluid. Okay. Obviously, also, if strep goes untreated, rheumatic fever, rheumatic heart disease can also be a complication. Okay. Before they have a tonsillectomy, a lot of times a PT or a PTT, so looking at their clotting factors, is determined because if they have a prolonged clotting time, they're going to be more likely to have bleeding after a tonsillectomy. Okay. Also important to know if there's any bleeding disorders in the family or the child. Okay. Saltwater gargles, ice chips, antibiotics, Tylenol, or acetaminophen, or ibuprofen as needed for the fever. Okay. After a tonsillectomy, signs of post-op bleeding, so frequent swallowing. So if a kiddo just had a tonsillectomy and parents call you saying that they're swallowing a lot, or they keep clearing their throat or they're vomiting blood, then those kids need to go straight to the ER, because kids can bleed really quickly and bleed a lot with post-op bleeds from tonsillectomies. Okay. Okay. What's the purpose of bronchodilators?
Open up your airways.
Yeah, can you give me an example of one?
Open it up for asthma.
Albuterol.
Yeah, albuterol. Yep, good. What would be a physical assessment finding that you would find with a kiddo who's having an asthma exacerbation?
Wheezing.
Uh-huh. Yeah. Do you guys remember what type of wheezing? Is it usually inspiratory or expiratory?
Is it expiratory?
Expiratory. Yep. Good. Okay, what do we do to support nutrition of kids with cystic fibrosis?
Give them those pancreatic enzymes before they eat their food.
Yep. And then what else? What type of vitamins do we have to give them?
They need a
Soluble.
they need a good intake of salt.
Yep, fat soluble vitamins. But we have to give them in water soluble forms. What was that, Jamie? Sorry, I didn't hear you.
I think it's A, D, K, and E.
Yep. Yep, those fat soluble vitamins. Good. So why is genetic counseling for family who has a child with cystic fibrosis important? Do you remember how cystic fibrosis is inherited? Uh-huh.
Oh, it's inherited through so if the mom has the gene and the dad has the gene, then the child will have cystic fibrosis.
Yes, good. Yep. Okay, tell me 7 things that are signs of respiratory distress in kids.
It's wheezing, like difficulty breathing.
Yeah, give me signs of
Nose
that, though.
flares.
Oh, yeah.
What did you say?
Nose flares.
Yeah,
Nose
nasal
flare.
flaring. Yep.
Breathing with their
Yeah, their accessory muscles, so like using their rib cage to breathe or their belly to breathe, right? Okay.
Noses in the lips.
Yeah, like pursed lips. Yep. What else? What are their vitals going to look like?
They're gonna have tachycardia.
Yep. What else?
It's going to be increase in their heart rate.
Yep. So tachycardia. Yep.
retractions.
Yep. Good. What about their respiratory rate? Is it going to be slow or is it going to be fast?
It's gonna go down.
Well,
First, it's fast.
First it's fast, then it goes down, right?
Yep. When they're no longer compensating, which
Oh.
means not good. Okay. What about their oxygen?
Low.
Oxygen low, but carb
PaCO2.
is going to be up, right?
Yep. Yep. Good. Good. What's another late sign? Like when looking at their skin.
Their color. It's gonna look
Cyanosis.
grayish.
Pale.
Yep. Pale, gray. Yep, cyanosis, good. Good. All right. What about if you have a kiddo in a mist tent or an oxygen tent? What's the one thing you want to be looking at?
Their temperature?
Yes, good. Because the mist could be dropping their temperature. Okay. If a kiddo comes in and they have epiglottitis, how are they going to be sitting?
Straight up.
Straight up, maybe?
What, high five?
On their side.
Like tripoding.
Tripoding. There you go. So they're going to be leaning forward with their arms out, usually trying to sit up as high as they can to get as much air in as they can. And then they're also going to be uncontrollably drooling, right? Because they can't swallow any of their secretions. Good. Why are fluids important if kids are having an increased respiratory rate?
Is it electrolyte imbalance because they like getting rid of the fluids as they like trying to like
Because
breathe
they're
and stuff?
compensating, right?
Yes.
Their body's compensating. Their blood pressure is gonna drop as they compensate, right? So they're gonna need replacement fluid. Good. Kids with chronic otitis media are at risk for developing what? If they have chronic ear infections, what could happen?
Is it a respiratory infection?
Well, they could have a respiratory infection that started the chronic ear infection, right? But what happens if those kids just continue to have chronic infection and fluid in their eardrum?
Will they lose their hearing? Will they lose their hearing?
Yes, their hearing can be affected. Okay. Good. What's the most common post-op complication of tonsillectomy?
That bleeding and the child swallowing the blood and potentially vomiting.
Yeah. So signs of bleeding, vomiting, right? Frequent swallowing, and then throat clearing. So those are all signs after a post-op tonsillectomy. If kids start doing those things, that parents need to be bringing those kids in right away to the ER. Okay, good. Okay, any questions on respiratory or the ear infections before we move on to cardiac stuff?
Sorry, I have one question because on the previous slide, it said the PO2 range is 83 to 100. I just wanted to, that's referring to the O2 sat rate?
That's
Or is that
referring
the
to blood
blood
gases.
Okay, thank you.
Yep, because your O2 sat, if it's 83%, that's not good.
Right, that's why I
Uh-huh.
had to double check.
If
Thank
it's
you.
less than, yep, if it's less than 90, they're not appropriately oxygenated. Okay. Yep, good.
I have a question about that.
Uh-huh.
Because on the last exam, we were told that anything 90 and higher is okay, but for the HESI, it was going to be different. So for the HESI, is it 95 and above?
95 and above is ideal.
Okay.
Yep.
Okay.
But like in looking at your normal ranges for kids, so a healthy kiddo should always be 95 and above. If they have a respiratory illness and they're in the hospital, you want them to be 90 and above.
Okay, thank you.
That makes sense.
Yes, thank you.
Yep. Okay. Congenital heart defects or heart disorders, they like to ask about these. Like I said, they really like to ask about things like tetralogy of Fallot that have multiple defects. Okay, because then that way they can test you guys on knowing all of those different defects. Okay. Acyanotic disorders, they're going to have increased circulation to the lungs before then it goes out to the body. So these kids are not going to be cyanotic. Okay. Cyanotic heart disorders, there is decreased circulation to the lungs and more increase to the body. Okay. Polycythemia is a form of, you guys remember, anemia, right? So kids with cyanotic lesions are more likely to have anemia, polycythemia specifically. Okay. And diagnosing cardiac disorders in kids, looking at EKG, which that looks at the electrical rhythm of the heart, okay, and the electrical pathway of how that heart is contracting. And an echo is looking at the actual anatomy of the heart with an ultrasound. Okay. So some signs and symptoms potentially of a cardiac abnormality, obviously irregular heart rate, rhythm, abnormal heart sounds, changes in their blood pressure. Okay. So they may have a murmur, they may not. Okay. You might hear a friction rub or a thrill, which is kind of that high-pitched noise. They may have irregular pulses, so their pulses in their upper extremities may be more strong than their lower extremities, or their blood pressure in their upper extremities might be higher than their lower extremities. Okay. Cyanosis, clubbing, so that's that finger, their fingers become really like rounded, their nails, and thick. And that usually happens after they've been cyanotic for quite some time. So usually not until after 2 years of age that you're noticing that. They're going to have poor feeding, poor weight gain. They're going to be failure to thrive. A lot of times they have acid reflux. So they're spitting up a lot. And no matter what you do for them, they're going to continue to spit up. They're going to get really fatigued easily. Okay. There might be a history of a maternal infection during pregnancy. So if mom had an infection, so an STD or something during pregnancy, sometimes that can affect their risk for having congenital heart defect. Okay. Know your normal heart rates for kids. It's not one age group across the board range. So know based on ages. That will help you with answering some of your scenario kind of questions, okay? And obviously the heart rate is going to increase if they have a fever or if they're crying and upset. That's just kind of a normal physiologic thing that happens. Okay? Nursing plans and intervention for kids with congestive heart defects. Obviously, because they're going to be failure to thrive, you're going to be monitoring their intake. Okay. These kids may need smaller, more frequent feedings, because if they're feeding for a really, really long time, then they're using a lot of their energy and burning more calories than what they are getting. Okay. High calorie formula, it might need to be, they may need to be on like 27 calorie formula instead of 21. Okay. Just so that way they're getting more calories in those feedings as well. You can also fortify breast milk to be higher calorie as well by adding formula to it. Okay. Infants may require like NG tube feedings if they're working really, really hard to eat and they're not able to consume enough calories. That's something that you will see commonly. And you want to make sure that they continue to get a pacifier while they're on tube feeding, so that way they continue to have that sucking reflex. Okay. Heart failure. So this happens obviously when the heart is unable to effectively pump the blood volume. Okay. It's associated with acyanotic defects, more likely. Okay. So signs of heart failure, tachypnea. So high respiratory rate, tachycardia, high heart rate, shortness of breath, like they can't catch their breath. They're cyanotic, having problems feeding, grunting, wheezing. Their lungs sound really wet, right? Because they're getting pulmonary overload. Edema, diaphoresis, weight gain. Okay, so if you have a heart kid, you're going to be getting daily weights at the same time of day. And obviously, if there's changes in their weight gain, then that's getting to be concerning. And eventually, their liver will enlarge. Okay. Okay. Things you're going to be doing for kids who are in heart failure or progressing to heart failure, monitoring their vitals and reporting any abnormalities or increased distress. Now, heart kids, they may normally, like their normal blood or their SpO2 normally maybe 80%. That might be their normal. That might be the best that they can get. So these heart kids are going to have different vital ranges depending on their defects. Okay. Monitoring their respiratory status, elevating their head of the bed, giving them DIG, making sure you know your ranges on DIG. Okay. On why you would get it or why you would hold it. If their heart rate's too low, you would hold it, right? And if their blood pressure is too low, you would hold it. Okay. Diuretics, these kids a lot of times will be on diuretics because you're trying to give them fluid, but also get rid of the fluid at the same time. Remember weighing diapers. That's really extremely important in heart kids. So 1 gram of the diaper weight is equal to 1 ml. Okay. Any unusual weight gain, we kind of already talked about that. These kids will be on low sodium diets. Okay. Formula or breast milk. Gavage feeding, so that's through that NG feed, but make sure that they are having a passy at the same time. Okay. When you're doing weights, obviously with these kids, it's very, very sensitive. So you're weighing them the exact same. So if you weighed them naked, then they need to be weighed naked on the same scale and at the same time of day. Okay. Okay, rheumatic fever. So this is associated with strep, group A, strep only. Okay. A lot of times it affects the aortic and mitral valves of the heart. So this is why it's important to treat group A strep. They will be on long-term penicillin prophylaxis, usually, ideally, bicillin injection. So that's once a month. Otherwise, they'll be on penicillin twice a day. Okay. It's at least 5 years from when they were diagnosed. And rheumatic fever is also one that they'll use aspirin at times. Okay. Okay, Kawasaki. So this is an acute systemic vasculitis. So it's damage to the blood vessels. This includes the coronary arteries of the heart, and it can also include the vessels in the brain. Okay. High fever for 5 or more days. They're going to have conjunctival redness. So they're going to have, like look like they have pink eye, but they don't have the goop with pink eye. They're going to have strawberry tongue. Literally, they're going to stick their tongue out at you and it's going to look like the surface of a strawberry. Red, swollen hands and feet. And they're going to be extremely irritable. Okay. You guys will help RNs give IV immune globulins or IVIG, okay, with these kids. treating fevers with Tylenol. You're going to be looking at their cardiac status, making sure that their INOs and they're maintaining their daily weights. You're going to want to minimize skin discomfort because they're going to also a lot of times have rash all over. So you might need to be giving them cool compresses. Okay. Mouth care is going to be needed to be meticulous with these kids. And then usually clear fluids and soft foods. So that way they're at decreased risk for bleeding. Okay. All right. Looking at right to left to right shunting. Okay. So right to left shunt is associated with what defects?
The right to left, the acyanotic, or is the
Right.
other way around?
Right to left is cyanotic.
Okay.
Yep. Left to right is acyanotic. Okay. Okay. What are the 4 defects with tetralogy of flow?
This is a ventricular septal defect, the ASD, the VSD, and I forgot the other.
So it's a VSD. What's wrong with the aorta?
Oh, it's narrow, the coartication.
Overriding, right? So it's in the wrong spot. So it's getting blood from both sides of the heart. Okay. Your pulmonary artery is stenotic. So that means that one's narrow. Melissa, I think that's the one you're thinking of. And then what happens to the right ventricle? Does it get smaller or is it more muscular with tetralogy of flow?
It's bigger.
It's bigger, right? Because it has to pump all the way to the body because of the shunting from the left side to the right side. Yep. Good. Okay. What are signs of a cardiac problem in an infant?
Tachycardia.
Yep. What else?
Fatigue,
Yep.
edema, or fatigue while feeding, I guess.
Yeah. Well, general fatigue too. Yeah. Good. So they're not, what about failure to thrive? They're not going to grow like they should, right? Yep. What about respiratory wise? Gonna work harder with their lungs or?
Is it the
Well, they
wet
have-
lung?
Yeah, so more likely that they're tachypnic too, right? They're breathing faster to compensate. Good. All right. What are 2 goals or 2 objectives when treating heart failure?
Getting rid of that fluid,
By using what?
a diuretic,
Yeah. What else? We talked about DIG. What does DIG do?
digoxin. So what digoxin does, it strengthens the heart
Contractibility.
yes,
Yeah.
and
Yeah.
it makes the heart not work as hard.
Yep. Yep. Because that muscular contractibility. Yep. Good. So those would be two things. What else? What else would be a really important sign? So like you're monitoring for heart failure, what would be one big change that you would want to let that provider know?
Is it a blood pressure?
Potentially. What about weight gain? Right? That's going to be your biggest sign. Okay. Because they're probably holding on to that fluid, right? Or a decrease in output versus input. Good. All right. What position relieves a TET spell?
Knee to
Knee
chest.
to chest.
Knees to chest, or have them squat down, right? And
Mhm.
what does that do? Does that increase or decrease the return to the heart?
It returns.
Increase.
It increases the
Venous
return.
return, the blood return. Yep. Yep. Increase. Good. Good. Okay. What's a common sign of dig toxicity? Forgot. Vomiting.
Vomiting, nausea, vomiting, and
Yes.
lows.
Yes. Good. Okay. What are some risk factors for cardiac cath? Like the kiddos had a cardiac cath. What are some things you're watching for as a nurse?
If it dislodges or something, I'm not sure.
Well, so they went in through usually the femoral vein or the artery, right?
Mm-hmm.
So if they're going into a vein or an artery, there's an opening there, right?
Sure.
So you would be concerned then about bleeding, right?
Oh, okay,
From
yeah.
that site. They'll need to lay flat, usually for a period of time. They'll have that pressure dressing on.
Oh, so like risk of infections and stuff like that?
Risk of infection, yep. Risk for bleeding, right?
Okay. Uh-huh.
Decreased peripheral pulses, right? Decreased sensation in that leg. There might be a blockage, right? A clot that's formed.
Okay, yeah. Okay.
Yeah, all that stuff.
Okay.
Okay, so things that you'd be watching for after cardiac cath. Good. What are the most common cardiac complications associated with rheumatic fever? What defects? Aortic. Do we remember? Let's look. Aortic and mitral valve is usually what it affects. Okay. So it affects the valves of the heart. They're not able to function as well with rheumatic fever. Okay. Okay, and then what medications do we use to treat rheumatic fever?
Penicillin.
Penicillin, aspirin, and acetaminophen.
Yep. Good. Perfect. All right. Any cardiac questions? Once again, cardiac stuff's hard, but they like to ask about cardiac things. Okay.
I'm sorry, I did want to ask if the rheumatic fever was more acyanotic or cyanotic.
That's not so it's not like it's not a cardiac defect. That just affects the valves. So it's not going to cause cyanosis.
Okay.
But it's not like an actual official cardiac defect. Does that make sense? So it's not one of the cardiac defects that you look at, acyanotic versus cyanotic.
I guess like I get it.
Like VSD and ASD, those are acyanotic, right? Versus tetralogy float, those are going to be cyanotic. Okay. Neuromuscular disorders. So Down syndrome, that's from an abnormality in trisomy 21 chromosome. Okay. Kids with Down syndrome are more likely to have cardiac defects, so they're more likely to have ASDs or VSDs. They're more prone to respiratory infections. They're going to have difficulty feeding. Why are they more prone to respiratory infections, kids with Down syndrome? Think about their facial anatomy.
What, the drooping?
So how about their nasal bridge, right? They have that flat nasal bridge.
Oh, so it makes it difficult for them to breathe?
Yes.
Okay.
Yep. Good. Feeding difficulties. That goes along with, if they have a respiratory issue, a lot of times feeding is more complex. Developmental delays, cognitive impairments, and they can also have skeletal defects, which, like I said, flat nasal bridge. Okay. Kids also with Down syndrome are more likely to have leukemia as well. Okay. Your priority goal as a nurse in caring for a child with Down syndrome is to allow them to function at their optimal level. Okay. Cerebral palsy or CP. So risk factors for CP, low birth weight or maternal infection. So mom gets some sort of infection while she's pregnant. That's going to increase the risk factors for CP. Okay. Complications of CP, a lot of times these kids have cognitive impairments, so they're developmentally delayed. They a lot of times have seizure disorders, and they also are failure to thrive often. Okay. When you're feeding kids with CP, it's important to talk about preventing aspiration. Okay. So you're going to need to position these kids in certain ways. So have them be upright. Okay. And also when you're feeding them, a lot of times because they lack the musculature to kind of hold their jaw shut appropriately, a lot of times you have to kind of prop their jaw as they're bottle feeding as well. Okay. But the most beneficial thing is to hold that child upright as they're feeding. Okay. Okay, spina bifida. So most common complications with spina bifida is also hydrocephalus, which is increased fluid in the brain. Okay. That happens with about 90% of myelomeningocele, which is the more severe form of spina bifida. Okay. These kids a lot of times are going to have neurological impairments. They're going to have a neurogenic bladder, so they don't have that good tone or that sensation that they need to control their bladder. A lot of times they have hip dislocations, so developmental hip dysplasia, clubbed feet. Okay. Scoliosis, so curvature of their spine. And then the other thing with spina bifida that a lot of tests like to ask about is what's the most common allergen, and it's latex. Okay. Now, while mom's pregnant or in childbearing or child rearing age group, it's recommended for them to take folic acid. Okay, and that reduces your risk of neural tube defects, which spina bifida is a form of a neural tube defect. Okay. Okay, hydrocephalus. So there's an obstruction in the flow of the CSF, so cerebral spinal fluid, between the ventricles. Okay, and then that results in the ventricles becoming enlarged and then increased pressure on the brain tissue. Okay. Meningitis and spina bifida are going to be your two risk factors for hydrocephalus. Okay. And increased intracranial pressure signs are the opposite of those for shock. Does that make sense? So you're gonna have decreased pulse and increased blood pressure for increased ICP. And increased pulse and decreased blood pressure if they're in shock. Looking at that child's baseline usual behavior, that can kind of also tell you if there's signs of changes in the intracranial pressure. Okay. Monitoring for signs. So looking at those increased blood pressure and decreased pulse rates. Okay. Kids with hydrocephalus a lot of times are also on seizure precautions. Okay. Or kids who are more at risk for increased intracranial pressure are going to be on seizure precautions. Elevating the head of the bed is helpful. A lot of times they have it set to where you can't lower the head of the bed past 30 degrees in kids with risk for increased intracranial pressure. Okay. Kids with hydrocephalus, they're going to have a shunt inserted into the ventricle to help that drain that fluid appropriately. Okay. Sometimes that tubing is then tunneled into the skin. Like a lot of times in the abdomen, they'll have a place where that excess CSF drains within the abdomen. Okay. It's really important that if kids have ventricular shunts or VP shunts, that those are not bumped or hit in any way, because it can throw off the function of that. And then by hitting it, it increases the pressures in the ventricles. Okay. All right, seizure disorders. Remember, there's different forms of seizures. So tonic, clonic, or convulsive used to be called the grand mal seizure. So consciousness is lost. They have tense and relax, tense, relax. Okay, and their whole body's involved. Tonic is when they have generalized stiffness of the entire body. And then clonic, like I said, is that spasm after spasm and then relaxation. Absent seizures or petit mal seizures, that's when they're just kind of staring off. They might kind of momentarily seem to be altered levels of consciousness, but they maintain their posture. Okay. They might even just have like a few blinking tick, like a tick can be a form of an absent seizure. Okay. Myoclonic, so this is where sudden brief contracture, so the muscles contract and tighten up, and then they go back to their normal state. Kids don't have postictal state, so they're not out of it like they are after tonic-clonic seizures when they've lost consciousness. Okay, atonic seizures, this is when kids just drop all of a sudden and start having a seizure. So they lose all tone and drop to the ground. Okay. Non-compliance with medication is the most common reason why kids have increased seizure activity. So explaining compliance, like it needs to be taken at the same time of day every day for maximum compliance. And then do not insert a tongue blade into the child's mouth during a seizure. Okay. Causes more harm than good. Roll them on their sides. Make sure that they're, away from things that they could hit their head on. Okay. All right, bacterial meningitis. This is inflammation of the meninges that cover the brain and the spinal cord. Meningitis is inflammation of the brain and the spinal cord. Okay. Encephalitis is just the lining of the brain. Okay. Bacterial root, usually it comes from a middle ear infection or from the nasal pharynx route, so an upper respiratory infection. The exudate or the bacteria then causes covers the brain, and the cerebral edema then results. So then you get the cerebral swelling. Antibiotics, usually these kids are started on a rotation of antibiotics, usually AMP and GENT or Rocephin, and then also antipyretics. So they're going to be given, acetaminophen, Tylenol, or ibuprofen to help manage their fevers. They need to be isolated for at least 24 hours after the initiation of antibiotics, prior to, having a lot of visitors. Monitoring vital signs, you're going to also be monitoring their neurological status frequently, maintaining a quiet environment to prevent them from becoming overstimulated, and also these kids will be on seizure precautions. Okay. So remember, meningitis is inflammation of the meninges of the brain and spinal cord. Okay. The head of the bed's going to be slightly elevated. Okay. They may also lay on their side. In infants, you're going to be measuring their head circumference daily. Okay, monitoring for increased intracranial pressure. Okay, and looking at their INO. The most common type of bacteria that causes bacterial meningitis is Haemophilus influenza type B, which is that Hib bacteria again. Okay. So there has been a decrease in bacterial meningitis since we've done that vaccine, but it still happens. Okay. They may also be having inappropriate ADH, so antidiuretic hormone secretion, which is causing cerebral edema. And then in dilutional hyponatremia. So because they're overloaded, they're going to have lower sodium. And they're holding on to their fluid because there's an imbalance in their antidiuretic hormone. So they're not urinating and getting rid of that fluid like they should. Okay. Okay, Rye syndrome. This happens with flu, chickenpox, and aspirin usage. Okay, what's Rye syndrome?
It's like when you get like your skin falling off, you got like that red rash all over your body.
So that's actually Stevens-Johnson syndrome, or like scalded skin. So Rye syndrome happens. Oh, go ahead.
Sorry, I was gonna ask if that's the enlarged liver and brain.
Yes, swelling in the brain, liver damage, confusion. Yep. Good. So they can start to have diarrhea because of the liver dysfunction and all of that. But yes, it's mostly affects the liver and the brain. Okay. Okay, a brain tumor. So signs of a brain tumor: headache when they're waking in the morning is one of the most common signs of a brain tumor. Okay. So the second they wake up, they have a headache. Okay. Vomiting, also usually in the morning when they're having that headache. Okay. And it usually just comes right out of nowhere. You know, sometimes you feel nauseous before you vomit. Kids with brain tumors, they usually have no signs of nausea, they just vomit. Starting to have behavior changes or personality changes, troubles concentrating, vision problems. In infants, you'll see their suture lines, you know, those suture lines that are soft so baby can pass through birth canal. They'll start to widen. They'll have more of a tense fontanelle, so bulging fontanelle. Older kiddos, you'll see their walk change often. Okay. They start to lose skills that they had previously accomplished. Okay. So post-operatively, if a kiddo is having a brain tumor removed, depends on the location of the tumor, but a lot of times they're laying flat on their back or they're able to turn from side to side. Okay. Once again, you're looking for increased intracranial pressure. And you want to be monitoring INO so that way they're not becoming overhydrated, because that will increase their risk for increased intracranial pressure. Okay, muscular dystrophy. This is inherited and boys are affected. Remember, especially Duchenne's muscular dystrophy. They're going to have that lordosis, so that abnormal curvature of their back, a waddling gait, Gower's sign. So this is, they have to, so they're sitting on the ground. They can't just go from sitting to standing. They have to use their hands to kind of walk themselves up to standing. That's called Gower's sign. Kids are doing that. It's not uncommon that they have some form of muscular dystrophy. False hypertrophy, so pseudohypertrophy of the muscles in the calves begin to happen, and that's because of fat deposits in those areas. It's not actually because, you know, they're working really hard with those muscles. Okay. Degeneration of musculature typically happens over time, and eventually it will affect the cardiac muscle and the respiratory drive. So eventually these kids usually die from, you know, a cardiac event or a respiratory event. Okay. These kids are eventually wheelchair dependent and then confined to bed. Okay. All right. What are some physical features of a child with Down syndrome?
You'll have like the drooping face. I say drooping face. I don't know what it's really called, but you know, the facial stuff.
Yeah, so the flat nasal bridge. Usually their eyes are wide set, right? So their eyes are further apart. Low lying ears. So like instead of having ears kind of in alignment with your eyes, they're going to be lower. Anything else? Okay. So with neuromuscular disorders, one form that's abnormal with their gait is called scissoring. And that's when they actually kind of crisscross their legs as they're walking. So they're going to step one in front of the other. Okay, and that's a very common sign of a kid with a neuromuscular disorder. Okay. What are 2 nursing priorities for kids with myelomeningocele? There are 2 things you really want to do. Okay, what's myelomeningocele?
Is it a
Not with the
defect
spinal
in the
cord.
spinal cord?
Yeah, so it's spina bifida, right? That's the most severe form of spina bifida. So the spinal cord, that pouch is outside of the area that it should be in. So it's outside of the body, right? It's protruding.
You gotta keep it moist.
Yeah. Yep. What else? What's going to happen if they have a spinal cord or a spina bifida like that? Are they going to have good bladder control? You're going to
No.
probably want to watch their INO, right?
Mhm.
Good. All right. What are some signs and symptoms of increased intracranial pressure in older kids?
Is it nausea, vomiting,
Yeah.
seizures,
Yeah.
high blood pressure?
Yeah. What
Tachy,
about their pulse?
could it be fast? Oh no, low, down.
Yep. Good. All right. What about parent teaching when their kiddo just got a VP shunt? What's some things to teach parents about?
Lie them flat, not on the side of the shunt, right?
Flat.
Yeah. Or slightly elevated, whatever.
There you go. Yep. Good. Because laying them flat's going to increase that pressure, right? Yep.
Mhm.
What else? Not hitting the shunt, right? Being careful not to hit the shunt because you can throw off the flow and all of that. Okay. All right. What are your 3 goals in providing nursing care to a child with a seizure?
Airway, safety.
What do you mean by that?
What about safety? Moving, like making sure they're in an area where, or moving things around so that they
Yeah.
won't hit their head.
Yeah.
And I guess incontinent.
They're probably going to be incontinent. Yep.
Is it what? Take their meds as prescribed?
Yep. Yep. Good. And then also laying them on their side, right? Because a lot of times these kids vomit. So that way they're not aspirating their vomit. Okay. Signs and symptoms of a child with meningitis. What do kids with meningitis look like?
That's the swelling of the brain, correct?
Yeah, the inflammation of the brain and the spinal cord.
It's bulging. They're gonna have bulging fontanelles, right?
Yep, if it's an infant. Yep. Good.
Headaches.
Headaches. Yep.
Fever.
Fever. Yeah.
They might not want to eat or
Yeah.
feed.
Yeah. What about their like cognition? Like, do you think that they're really with it if they have an infection of their brain and spinal cord? Right. They're probably going to have a change in their cognition, right? So they're not going to be as alert. Maybe they're more lethargic. Okay. Or they're not as responsive. Good. Antibiotics that are usually prescribed for bacterial meningitis. We talked about ampicillin, Rocephin, gentamicin. How are children positioned after brain tumor surgery? To Kayla, you said this earlier. Lying.
Flat.
Yeah, more flatten on their side. Sorry, I guess I see now you haven't just took a bite, but yep, more likely to lie flat and on their side. Okay. What's the inheritance pattern of Duchenne's muscular dystrophy?
We're on number 11.
Oh, I skipped that one. You guys should know that interventions for
Yeah.
increased ICP by now, right? We've talked about that a few times. What's your interventions for increased intracranial pressure?
What you gonna monitor the in eyes and nose?
Yeah,
Monitor for seizures.
yeah. Have their head bed elevated, right?
Mhm.
Yep. It might be getting something like mannitol or something to decrease the pressures in their brain. Yep. Okay, so what's the inheritance pattern for Duchenne's muscular dystrophy?
That's the one that's common in boys, right?
Yes, only in boys. Yep.
Mm.
And it's X-linked inherited. Okay. And Gower's sign. Do you guys remember what Gower's sign was? So kids are on the ground and they can't just stand up, right? They have to kind of walk up their own body to get themselves up. And that's common in kids with muscular dystrophy. Okay. All right. Renal disorders. So acute glomerular nephritis. This happens after group A strep. Okay. These kids, it's diagnosed if they have an elevated BUN and creatinine and an elevated ASO titer, which that happens after strep infections. Kids get strep. If you check their ASO titer within a few days, it's elevated. Okay. That's a sign of if for some reason they didn't get treated for strep throat, you can check that. And if it's elevated, then you can assume that they recently had a strep infection. Okay. They're going to get mild to moderate edema, most commonly around the face. Okay. Sometimes they'll have, peripheral edema, so in their hands and their feet, but most commonly it's their face. They're going to be irritable. They're going to be lethargic. They're going to have high blood pressure, dark colored urine. So they're going to have hematuria. So that blood in their urine and protein in their urine. So when you do a UA on these kids, that's what you're going to see. Okay. So supportive care. So monitoring their blood pressure specifically. INO, you're going to weigh them daily. They're going to be on a low sodium diet, low potassium diet if they're not having good urinary output. If they're having good urinary output, then the potassium piece isn't as crucial as the sodium piece. They'll be given antihypertensive, so blood pressure medications if needed. You want to monitor for seizure disorders. Okay. Monitor for congestive heart failure and renal failure. Okay. Decreased urinary output is the first sign of the kidneys starting to fail. Okay. Constant urine specific gravity that's increasing is also an indication of renal failure, as those kidneys can no longer concentrate that urine. Okay. Okay, nephrotic syndrome. This happens with the glomerular tissue becomes permeable by plasma proteins. Okay. So edema usually starts and it's not really that severe and not usually noticed, and then it becomes progressively worse. And edema, this is going to be whole body edema with nephrotic syndrome. Okay. They're going to be lethargic. They're not going to eat well. They're going to be pale. They're going to have frothy urine. So when they urinate, it's going to look really frothy in the toilet. Huge amount of protein in the urine. Okay. If you draw their serum protein, like on the BMP or a CMP, it's going to be low because they're spilling all that protein through their urine. So it's not staying in their blood. Okay. And then they're going to have elevated lipids when you draw their blood levels. Okay. When caring for a child with nephrotic syndrome, monitoring their temperature and monitoring for signs of infection. Okay. Skin care is going to be important because they're going to have really edematous areas. So they're going to have decreased sensation a lot of time to those areas, but making sure that, you're repositioning often. Also, these kids are going to be on bed rest because they're having a lot of edema. So that's another piece of the skincare and positioning. They're going to be getting steroids, okay, to combat that nephrotic syndrome that's happening, the spilling of the proteins. Measuring their abdominal girth every day because the kidneys are affected. So if their belly is getting larger, what do you think is happening?
They retaining fluid.
Uh-huh. Yep. And their kidneys are probably getting bigger too, right?
Mhm.
As they're holding on to that fluid and they're getting further into renal failure. Small frequent feedings, normal protein, low sodium, and then remember low potassium if they're not having good urinary output. Okay. And weighing the child daily. Okay. Signs and symptoms of UTI. So infants a lot of times have vague symptoms. They might have diarrhea, vomiting, jaundice, strong smelling urine, fever, poor eating. Older kids, they're going to have more that classic kind of adult type of symptoms. So urinary frequency, dysuria, blood in the urine, urinary accidents. If kids start having urinary accidents and they've been a kiddo that's done pretty well with potty training, I mean, obviously common, the first thing you would do is check for a UTI. What would be the other thing you would get concerned about if they start having urinary accidents? And they're an older kiddo. Diabetes. Yep. What else?
Sexual abuse.
Yep. The sex abuse. Yep. And it's not always, I guess, it's not always sex abuse specifically too. They can have kind of regression and potty training and things with physical or an emotional abuse as well. But a lot of times, sex abuse. Okay. Nursing plan. So if you suspect a UTI, obviously checking their urine is one of the first things you do. Collect a clean catch. Okay. So they need to clean before. And in infants, it's going to be hard to collect a clean catch. So those kids will be straight cath. Okay. So they'll be catheterized for their specimen. Completing all the antibiotics as prescribed. Okay. Because we don't want, the kidneys to be affected. Okay. Sometimes you have to do follow-up specimens to make sure that infection went completely away. In little girls specifically, making sure that they're not doing a lot of bubble baths or wearing really tight undies. Okay. Increasing acidic foods that they eat. So like eating more apples or cranberry juices, that helps reduce your risk of UTI. Voiding frequently, not holding on to their urine until the very last second. Okay. And then cleaning from front to back. So those are all kind of interventions, hopefully to reduce the risk of UTI. And things that you can teach parents to kind of monitor and be aware of. Obviously, if infants or young boys are getting recurrent UTIs or frequent UTIs, you're more concerned about there being anatomic abnormalities. Okay. So something in their development happened that is allowing them to be more prone to UTIs. Okay. All right, Wilms tumor. Do you guys remember the one thing with Wilms tumor? The most important thing. No pushing on the belly. Remember, because this is that tumor that's really, really fragile. And if you push on the belly, you're going to flake off pieces of the tumor into the abdomen. Okay. So no pushing on the belly with Wilms tumor or nephroblastoma. Okay. These kids will have a mass in the flank area. Okay. So in the abdominal cavity, usually along the flanks, so along the sides. Okay. As it gets larger, it gets closer to the midline. Okay. Parents usually find this when they're bathing the child. Okay. Fever, pale, lethargic, higher blood pressure. Sometimes blood in the urine, but that's when they've had the tumor for a really long time. But the biggest thing to know about Wilms tumor is no belly palpitation. Okay. Okay. Hypospadias, epispadias, the surgical correction happens before preschool. So before toilet training. Okay. And then that's hypospadias is on the what side?
Is it the left side?
It's either on top of the penis or below.
Below.
Yep.
Below.
Yep. Good. So that's just the abnormal opening of the urinary meatus. Okay. So another sign of, other than just visually seeing that the urinary meatus is not in the correct spot, is if this child's having kind of an abnormal voiding stream. Okay. Okay, renal failure, acute renal failure, that can come about from dehydration or trauma to the kidneys, or a ureter obstruction like a kidney stone. Okay, that can cause acute renal failure. Okay, as far as chronic renal failure, that's going to be your kidney abnormalities or infections. Okay. Okay. What are some signs and symptoms of acute glomerular nephritis? What's acute glomerular nephritis from? Let's start there. Not finishing their antibiotic for strep throat, right? Yep. Okay. And it's a renal issue. So what do you usually see? What signs do you see with renal issues?
Retaining fluid.
Uh-huh.
Like really concentrated urine.
Yeah. What about their blood pressure? Is it going to be low? Is it going to be high? Is it going to be normal?
High blood pressure.
High blood pressure. And what about their urinary output? Or is it going to be normal or
It'll be
increased?
less.
Decreased. Good. Good. Okay. What's your dietary interventions?
Low sodium.
Yeah. Good. They're going to have decreased urinary output. So what are you going to also avoid?
Avoid potassium.
Yes. Good. Okay. Good. What about the physiologic reasons for low protein in the blood with nephrosis? Why does that happen? Why is the protein low in the blood with kids with renal disorders? Do we remember? They're spilling all their protein in their urine, right? So they're going to naturally have less protein in their blood for that reason. Okay. Okay. So a lot of these kids are going to be on prednisone or steroids. What are some things to tell parents when kids are on prednisone? What are they going to have to watch for?
They are going to have to watch for infections, because while they're on a steroid, it's going to make them more susceptible to sickness.
Yep. Good. What else? How's that kid going to behave? Have you guys been on steroids before ever?
Oh, they're going to gain weight.
They're going to gain weight.
And they're going to be jittery.
Yep. And irritable and angry, right? They're going to have a hard time sleeping, right? What about what time of day do you want to give the steroids?
Every day at the same time.
Yeah, morning time usually. The earlier you give them, the better, just because then it's less likely to affect their sleep. Okay. Good. And then what about withdrawal? Do you just stop steroids?
No, you have to wean them off.
Yeah. Yeah. If it's more than like 10 days, they have to be slowly weaned off. Yep. Good. Good. What can you teach parents and children to help prevent UTIs?
Wipe front to back.
Uh-huh.
Loose cotton underwear.
Yep.
Bubble baths.
Yep.
Increase intake of water and give them cranberries and cranberry juice.
Uh-huh. Yeah, acidic things. Yep, to increase your urine acidity. So you're less likely to have a UTI if your urine's more acidic. Good. Perfect. What about what's your priority for a kiddo with Wilms tumor?
Oh, don't
Don't
palate.
pop it out.
Yes, good. And then because they have cancer, right? What would be another priority with those kids?
What, the immune system, right?
Yeah, it's not going to function right because they're on chemotherapy.
Mm-hmm.
What are they going to be more likely to get?
Infections.
Uh-huh. Yep. So you're going to want to be monitoring for like fevers and all of that. Okay, good. All right. Why is hypospadias correction done before the child reaches preschool age?
Because that's when they're supposed to start potty training.
Uh-huh. What else developmentally? What are preschoolers scared of?
Body, the mutilation.
Yes, good. Yep. Yep. So if you wait much longer than that and you tell kids that you know that they're going to have a correction on their penis, they think that their penis is going to be totally cut off or really affected from that surgery. Yep. Good. All right. GI disorders, cleft lip and cleft palate. Complications, obviously kids with cleft lip and palate are going to have more difficulties feeding. They're going to have dental problems, speech difficulties, hearing loss, more ear infections just because of the way that their cleft lip and palate affects their eustachian tubes. Okay. And a lot of times these kids will have social and emotional and behavioral problems because they're not able to express their needs like a typical kiddo, and they're hospitalized often. Okay. Typical family reactions, a lot of times parents blame themselves if kids have cleft lip or palate. They may have a sense of anger, or feel, a dad may blame a mom or vice versa, for that. And then it's a lot of times helpful to take pictures before repair and then after repair. Just because that can decrease the feelings of disappointment in those families and show them that, you know, we're able to do interventions to kind of correct these things. Okay. Okay. Esophageal atresia or tracheoesophageal fistula. So these have to be corrected in emergent situations, right? Because these kids aren't getting the nutrition that they need through their esophagus, and it's going straight to their lungs instead. Okay. So this is going to be straight to the ER, or excuse me, straight to the OR. So pre-op cares, just like you would typically with another kiddo, with any kiddo who's going to be pre-op, you're going to be doing vitals, inserting IVs, monitoring their respiratory status. Okay. Sometimes you might have to suction if they're having a lot of secretions. Okay. Elevating that child at least to 30 degrees, so they're less likely to have the reflux. Okay. Prescribing oxygen if needed. And then these kids are going to be NPO. Okay. Because it's an infant, though, you still want that suck reflex to maintain intact, so provide them with a pacifier. Okay. Pyloric stenosis. So this is very forceful vomiting, right? So it's going to be across the room. They're going to hit the wall, very projectile. Usually about 2 weeks of age, this starts. Okay. The infant's extremely hungry. They're going to start to lose weight. They're going to not gain weight. Dehydration. They're going to be metabolic alkalosis. Okay. A lot of times you'll feel an olive-shaped mass in the right upper quadrant of the belly. Okay. You can also see the peristalsis of their guts on their belly a lot of times. Okay. So they're going to have surgery to correct this. Okay. Small amount of feedings first with like Pedialyte or glucose before they start on their formula or their breast milk. Okay. They're going to be right-sided semi-flowers after feeding, so that way they're less likely to have that reflux. Okay. Monitoring their weight and their eyes and nose. Okay, intussusception. So this is when our small intestines telescopes back within itself. Okay. They're going to have acute but on and off abdominal pain. A lot of times their legs are going to be drawn up. They're going to be screaming. Current jelly stools, so that means blood and mucus in their stools. Okay. Sausage-shaped mass in the right upper quadrant. Okay. And the right lower quadrant is usually empty. And that's called dance sign. Okay. Fluid and electrolyte balances are needed in these kids as well. Okay. And this is fixed by an air enema a lot of times, or they have to go in and have surgery. Okay, I'm going to run to the restroom really quick. So sorry. We're almost done. Okay, sorry, I thought I could make it the last 5 minutes, but I cannot hold it any longer. Okay, Hirschsprung's disease, remember this is where the ganglion nerves in the colon and the rectum are absent. So they don't have that sensation, so they get a large colon above where those ganglion cells are lacking. Okay. No rectal temps on these kids. Okay. They a lot of times will have a temporary colostomy set up, and then they'll have to have another surgery to reconnect and anastomose that tissue. Okay, appendicitis. Most common complications are rupture or an abscess. The pain's going to be where usually?
The right lower quadrant.
Yep. And they're going to have pain at McBurney's point, which is halfway between their belly button and their right lower quadrant. Okay, that's where their pain's going to be the worst. They're also going to have worsening pain. Is it worse when you push in or when you let go?
Is it when you let go?
Yeah, rebound tenderness is worse. Yep. They're also going to have fever. Okay. If their appendix has burst, or they have a perforation, then they're going to get temporary relief of their pain after the rupture, but then they're going to get really sick with fevers and all of that. Okay. Celiac disease. So this is an autoimmune disorder. The villi in the small bowel atrophy because of their response to gluten. Okay. So these kids are not able to eat gluten containing foods. They're going to have those steraturia, so those fatty mucousy stools. They're going to be really foul smelling. Okay. A lot of times they're going to have belly pain and cramping, and then growth failure. So maintaining growth and development by doing gluten-free diets. Gastroenteritis, this is inflammation of the stomach and the intestinal lining, typically from viral causes. So things like norovirus, rotavirus, okay? A lot of times they're going to be throwing up and having diarrhea, so you're going to want to monitor eyes, nose, monitor their stools. Because you're concerned for dehydration, you're going to be monitoring their neurologic status as well. Okay. Proper hand hygiene for both the patient, the parents, and you guys as nurses. Sugary fruit juices, sodas, really high sugar Gatorades, those can worsen the diarrhea. So make sure that they're not doing those. So if they're going to do an electrolyte drink, make sure it doesn't have a lot of sugar. And we do not give antidiarrheal medications for these kids because we want them to vomit and have the diarrhea, so they're getting rid of that viral illness instead of holding on to it. Okay. Okay, we'll do the review of GI disorders and then we'll hop off. Okay. So feeding techniques for a child with cleft lip or palate. Are they going to be able to use a normal bottle nipple?
No.
No, they have to have the longer nipple, right?
Mm-hmm.
Are they going to be able to nurse like a normal baby?
No.
No. Yep. Okay, what else are you going to want to do with the kids with cleft palate and cleft lip while feeding?
Keep them more upright. Keep them more upright.
Yep, good. Have them more upright. All right, what are your signs and symptoms of esophageal atresia or tracheoesophageal fistula? Remember, this is the pathway where the
Choking. Sorry.
choking. Yep. This is the pathway where the esophagus goes to the trachea instead of going to the stomach.
So
So
the
when,
food will go in their lungs.
right. So when they start eating, they're going to have respiratory distress, right? And then when they stop eating, the respiratory distress might kind of improve. Then you start feeding them again and they're going to have respiratory distress, right? Good. All right. Post-op teaching for an infant with pyloric stenosis. What are you going to teach?
They're gonna have that projectile vomiting.
Okay, but post-operatively.
Would you monitor the like fluids?
Yep. And what are they going to start with? They're not going to start with just formula or breast milk, right?
Is it like clear liquid stuff?
Yep. Yep. Good. And it's going to be small amounts, more frequent. Okay. Good. Why is a barium enema used to treat intussusception?
They have those jelly stools.
Uh-huh. That's a sign of intussusception. But what does the barium or the air enema do?
It's backwards, so to push it forward.
Yeah, so it pushes that telescoped portion back to where it should go. Uh-huh. Good. All right. What's preoperative teaching for a kiddo with Hirschsprung's disease? What are those parents going to need to know before their kiddo goes in to have the procedure? They may have a colostomy bag, right, for a period of time. And then eventually the colostomy bag should be resolved and they should not need that any longer, right?
Because they'll go in and cut out that area that's not working.
Yeah. Yep. And then reattach eventually. Yep. What is a focus of care if kids have colostomy bags? What's one of your priorities?
Is it that they maintain it?
Yeah, if they can maintain it, but what about like skin, right?
Skin breakdown.
Yeah, watching for skin breakdown. Good. Okay. What are signs of an anorectal malformation? So imperforate anus, right? So they don't have that opening of the rectum. So they're not passing meconium within the first few hours of birth. Not having good passage of meconium stools. Okay. What are your nursing priorities for a child undergoing abdominal surgery? So if they're having belly surgery, what's going to be affected after? Like what are some,
is it respiratory? I don't know.
so if they're having abdominal surgery, so they're having surgery because they have a GI issue. Are things, so are they going to be having normal stools after surgery?
Oh no. Oh, so diarrhea.
Uh-huh. Or like passing gas, watching that, making sure that they start passing gas.
Oh, make sure there's no bleeding and stuff.
Yep.
Okay.
Yep. Having good urinary output, not having fevers because they had surgery, right? Yep. All that kind of stuff. Good. Alrighty. I'll let you guys hop off here. I I know some of you guys have reached out to me already about going over concepts that we struggled with on exam 3. So if you decide that you want to chat with me again about that, just let me know. And we'll set up a time. Otherwise, make sure you're doing your practice HESI exams. There's 2 different ones that have to be done by Sunday for credit. Okay. And then also your net NCLEX questions and a discussion post this week. Okay. And then make sure you know when your HESI is and you're showing up there and making sure that you have all the things that you need. Okay. If you don't know your HESI time, reach out to your campus faculty. Okay.
After we take the HESI, do we have to come back on week 12 and sign in? Okay.
So, yep, on week 12. So on Monday, the 24th, I believe, is our week 12 day. I have times for you guys to sign up. It's under the discussion post course cafe. You can get to that. And if you guys want me to show you where it's at really quick, I can show you.
Okay.
Here, I'll do student view here and then I'll share my screen. And that way you guys can see what it's going to look like. So you guys, I already have this posted, so you guys are more than welcome to come in and sign up for a time that's going to work for you to meet with me. It will literally just be a 5 or 10 minute check-in, and that will be your attendance. So if you go from your start page, this little coffee cup right here, this course cafe, you click on that. And it should pull it up. Maybe my internet wasn't so slow. And I already have all the times here. So you guys can just go in and comment the time that you're going to use. If somebody else has picked that time, then pick a different time, please. And it will literally just be a 5 or 10 minute check-in to see if you guys have any input for the course or any questions or anything, okay?
Okay.
And then that'll be your week 12 attendance. But if you guys want to go ahead and start signing up for that, I'm totally fine with that.
Okay.
That way you've got it all set up. And if you don't have attendance week 12 and for some reason you miss your week 1 attendance for next term, then you know they can potentially drop you guys without asking questions. So it's really important for you guys to do that quick little check-in. Okay.
Okay. Thank you.
Yep.
Will we also get a video, a recording of this, what we just went over?
Yep. Yep.
Okay.
Yep. Just like usual, class.
All right.
And the HESI reviews are this week too. Okay.
Okay.
Okay. Thank you.
Yep. Take care, guys.